Hello all and welcome to Firetree's 8th monthly webinar. We do this webinar for family and community to reach out and educate them. My name is Kyle Miller. I'm one of the clinical supervisors here at Firetree at our Pottsville location, and I'm going to be your host this afternoon. If you have any questions, feel free to use the Q&A chat at the bottom of your screen as we move through the slides. And without further ado, let's get started. So what or who is MAT? The term MAT gets thrown around a lot, and it can be confusing with all of the different names. Often people think someone is referring to a guy named Matt, but that's not the case. MAT, or MAT, stands for medication-assisted treatment. It is the use of specific medications to aid in an individual's recovery in conjunction with counseling and other therapies. This is a very important distinction to make when talking about MAT. It's meant to be coupled with some form of counseling or other behavioral therapy. That's what it was designed for. This isn't a magic pill or a cure-all. The work still needs to be done and the habits need to change. The medications that are currently approved by the FDA for individuals struggling with opiate use disorder or alcohol use disorder are methadone, naltrexone, and Suboxone. And in this webinar, we're going to go through each one of these medications individually and look at some of the history behind them, their different functions, their names, and what they do. Prior to 1970s, a substance use disorder was seen as a moral failing and not a disease. Medication was not seen as a priority for an affliction that had everything to do with willpower. And the remedy, we thought, was to use your willpower, turn back to God, and rid yourself of the quote-unquote demon. And this is obviously outmoded and outdated. This is not what we believe today. It wasn't until advances in understanding the neurobiology of substance use disorder, the brain, and human behavior did we implement medications into the remedy. In 1974, methadone was approved by the FDA for the treatment of opiate use disorder. The need stemmed from wave one of the opioid epidemic starting back in the 1990s. The name changed from methadone-assisted treatment to medication-assisted treatment to help society see MAT as one in the same with medications for blood pressure and diabetes like insulin. And the goal overall was to reduce the stigma surrounding MATs. As you can see here, wave one of the opioid epidemic began in the 1990s due to the overprescription of pain medications. The problem is that most narcotic pain medication is highly addictive and it's finite. Eventually your script runs out and those with the physical dependence turn to heroin. And this is where wave two comes into play in the mid-2000s. Wave two is where we see Suboxone come into play, which I'll talk about a little later. Lastly, with wave three, we see synthetics like fentanyl come around and drastically increase overdose rates. As of 2022, there were 107,000 opioid overdose deaths. That's up there with deaths related to Alzheimer's and diabetes. So you can start to see the major importance and need for some sort of intervention here. So what is methadone and how does it work? Methadone is a full opioid agonist, and it's used to help lessen the withdrawal symptoms of illicit opioids so an individual can reduce their risk for overdose, they could get into treatment and maintain employment and be with their families again. At its simplest form, that's what MAT is meant for. Methadone is offered in liquid form, so you just drink it. This is given out at clinics, and you typically have to go there daily to receive your dose. And with enough clean time, some individuals do receive take-home doses lasting a few weeks or even a month. That way, they don't need to attend the clinic daily, and this makes things a lot more easier on the patient and manageable. Methadone dosing depends on things like tolerance, how bad your withdrawal symptoms are, and the amount of illicit opiates someone was using prior. Dose ranges anywhere between 10 and 150 milligrams. You can go up in dose or you can go down. That's one of the cool things about MAT. Because both methadone and other opiates like heroin, oxycodone, and morphine are considered full opioid agonists, chemically they are the same. This is often taken out of context though. Methadone is regulated and it's accurate. Simply put, you know what you're getting. Whereas with heroin or fentanyl, it's totally unpredictable. Taking into consideration the amount of overdoses that are occurring, we need to start seeing this from a harm reduction standpoint. Methadone is not without its criticisms, though. Ethically and objectively, we need to look at the potential downsides of methadone. Methadone is highly addictive because it is a full opioid agonist. You can and will become physically dependent on methadone, and you will experience severe withdrawal symptoms. And although therapy is always recommended, it's not a requirement at some clinics. This will depend on what state you're in and area, of course. And as I mentioned before, most patients do need to attend the clinic daily for dosing. This can be a major inconvenience depending on your means of transportation, employment, financial status, and distance from the nearest clinic. Overdose can and does happen on methadone, especially when it's mixed with other drugs like benzodiazepine and alcohol. As you can see in the figure to the right, prescription opioids, including methadone, contribute to a fairly high amount of overdose deaths, which has peaked at about 20,000 in 2021. This figure does combine methadone with other prescription opioids like painkillers, which I don't really like because they are different in many ways. But nonetheless, these deaths do occur, they do happen. Okay, so we're going to switch gears a little here and talk about Suboxone. Suboxone became FDA approved in 2002. The need stemmed from wave 2 of the opioid epidemic in the 2000s, which I referenced a little earlier. In contrast to methadone, Suboxone was seen as a safer and more accessible alternative to methadone. It's not as potent and has some unique properties, which makes it a much better fit than methadone for many people, and I'll go into detail as to why that is in the next few slides. As previously shown, we see wave 2 now of the opioid epidemic in the 2000s, which brought about the need for other treatments like Suboxone. Deaths were increasing and more accessible options needed to be presented. So Suboxone is a brand name for the combination of two compounds, buprenorphine and naloxone. Buprenorphine is the active ingredient in Suboxone, and it is a partial opioid agonist. Like methadone, its primary purpose is to quell withdrawal symptoms and allow the patient to regain control of their life and resume daily functioning. Naloxone, otherwise known as Narcan, which you might have heard about in the news, is added to Suboxone as a blocker and to reduce misuse of the Suboxone. Suboxone is typically offered in strip form that could be administered sublingually. This just means that you place it under your tongue and it dissolves, or it could be administered buccally. This just means that you place it in between your cheek and your gum line and it dissolves. Suboxone is offered in most common doses from 2 milligrams, 4 milligrams, 8 milligrams, and 12 milligram strips. So I've been throwing around these terms like full opioid agonist and partial opioid agonist. I mentioned before that methadone and other illicit opiates are considered full opioid agonists. I want to take a minute to explain what I mean by that. A full opioid agonist binds completely to the mu opioid receptor. For lack of better terms, this is the mechanism that gets you really high and provides the pleasurable euphoria that so many addicts constantly seek. On the other hand, buprenorphine or Suboxone only partially binds to the mu opioid receptor. The best way to understand and conceptualize this is to think of one of those boxing arcade machines that give you a high score depending on how hard you hit it. Some of you might have seen these at carnivals or in arcades. I hope you know what I'm talking about. But if your MU opioid receptor is the bag that you're punching and the high score that you get is the strength of the opioid binding to it, that would be a full opioid agonist. Now stay with me. Let's say you take the same boxing machine and you put it underwater and tried to play. You would never achieve the same high score as you did as if you were underwater or above water. This is how a partial opioid agonist works. The effects are very much so watered down. No pun intended. But to sum all that up, respiratory depression becomes limited with partial agonists. This makes overdose incredibly unlikely. It also allows for something called the ceiling effect to take place. Using Suboxone in higher or even unprescribed doses will not result in any greater euphoria or effect. This greatly reduces addiction potential, misuse, and overdose. Naloxone, otherwise known as the brand name Narcan, is considered an opioid antagonist. This means that it actively reverses the effects of opiates such as heroin, morphine, or oxycodone should they be taken in conjunction with your Suboxone. This is a great system for discouraging relapse and continued use for those struggling with opiate use disorder. Furthermore, because naloxone is activated when taken nasally or intravenously, this prohibits patients from misusing Suboxone intravenously or nasally. And you might ask why it's not activated when taken sublingually and affect the buprenorphine. But naloxone or Narcan is really poorly absorbed when taken sublingually. This prevents it from even being activated. So if Suboxone is injected or snorted, precipitated withdrawal is said to occur. And all this is a rapid onset of withdrawal symptoms instead of the withdrawal symptom coming on slowly over time. They come on all at once immediately. So next we're going to talk about Sublocade. Sublocade was approved by the FDA in 2017, and it's the latest and greatest form of MAT offered. Sublocade is the injectable version of Suboxone minus the naloxone. It consists of only buprenorphine. It is a subdermal injection, meaning it's just injected beneath or under your skin. And this shot lasts about 30 days and is offered in 2 doses, 100 milligram and 300 milligram. The treatment has little to no risk for abuse or diversion due to it being an injection administered only by a professional. There is no not taking your dose or diverting it to someone else or selling it. It totally eliminates that. It also eliminates the need to dose daily, resulting in a more consistent and streamlined effect. Because Sublocade's half-life is so long, traces can be found in a patient's system for up to 300 days after administration. That's incredible, and it can be seen as a good and a bad thing. Interestingly, this makes coming off of buprenorphine or Sublocade much easier. Because it leaves your system so slowly, withdrawal symptoms can be seen as mild in comparison. Here you can see the consistent and streamlined absorption of buprenorphine via the Sublocade injection. It eliminates the peaks and valleys associated with Suboxone with dosing oral Suboxone. So in red, you could see the oral Suboxone and it spikes, and then it falls off, and then it spikes. And obviously in blue, we see the Sublocade. It's a much more consistent dose. We're not trying to mimic using heroin or using fentanyl, and that's really how it is when you're taking oral Suboxone. You dose, you come down, you dose again. With Sublocade, like I said, nice consistent dose is what we're looking for. In 1984, the FDA approved naltrexone, not Vivitrol, for the use of opiate use disorder and alcohol use disorder. However, the original naltrexone was only offered in pill form, resulting in very poor adherence. So it was really easy to just not take your pill or take the pill whenever you wanted, drink, and then take the pill. It wasn't until the mid-2000s that Vivitrol was approved by the FDA for opiate use disorder treatment and alcohol use disorder treatment. Findings show much greater compliance to monthly injections over its oral counterpart. So lastly, we have Vivitrol. Vivitrol is an opioid agonist. It blocks the effects of alcohol or any opioid by binding to the opioid receptor, and it has no potential for abuse or diversion. It gives you no effect. It gives you no euphoria. It is non-addictive. And like other MATs, Vivitrol works best when part of a comprehensive treatment plan that includes counseling and participation in social support programs. For those that wouldn't be any wiser, should you inject them with Vivitrol and they weren't drinking, you honestly would never know you're on the Vivitrol. So I like to see Vivitrol as like wearing your seatbelt. It could save your life. It can't hurt. So here are some of the benefits of Suboxone and Methadone over illicit opioids. One of the big criticisms is that we are replacing one for the other. They're the same thing. It's a one-to-one comparison. And that couldn't be further from the truth. And I just want to dispel some of that right now. So as we talked about before, Suboxone has a ceiling effect. This reduces risk for abuse and overdose. Methadone, on the other hand, is regulated. Your dose is very closely monitored by professionals on a daily basis, where fentanyl or heroin, on the other hand, is an unpredictable amount. Not only is the amount unpredictable, but the potency and what's in it is also unknown. Illicit opioids like fentanyl are commonly mixed with chemicals like tranquilizers that increase your chance for overdose substantially. Suboxone and methadone are also less addictive because the route of administration allows it to be absorbed more slowly for these medications. The highly rewarding effects, or the rush that you hear about, is greatly reduced, especially for Suboxone. Remember, the rewarding effects are watered down because it's a partial opioid agonist. Fentanyl and heroin are considered more addictive due to their common administrations being nasally or intravenously. This results in the reinforcing euphoric effect. The main differentiating factor here is the immediacy of onset. You're getting the results immediately. Another major benefit to MATs that goes unnoticed at times are the legality of these medications. Not to say that the non-legal repercussions aren't noteworthy, but much of the negative consequences from substance use disorder or alcohol use disorder are the legal ramifications that come of it. Individuals lose years of their life incarcerated or in prison because of this. Another major benefit of MAT is that it allows the individual to get back to work and be present in their family's lives. When using illicit opiates, maintaining employment and being present with your family is obviously next to impossible. MAT is also structured in a way that makes it manageable to taper off. It is available in so many different doses precisely for this reason. Patients work closely with a counselor to collaborate together in slowly lowering this dose over time. MAT is also more accessible than ever today. Most PCPs at this time can prescribe Suboxone, and methadone clinics are located in all different areas across PA. I should note that Sublocade is a little bit harder to get your hands on, as it must be done by a certified professional. On the other hand, illicit opioids are incredibly dangerous to obtain. They're costly and they're illegal. Excuse me. Part of the importance of taking part in some kind of therapy, counseling, or behavioral therapy when taking MAT is that you address these maladaptive habits. Taking MAT is not just about satisfying withdrawal symptoms and replacing an opiate for another opiate. It's about allowing the patient to have the autonomy and the capability to address their thrill-seeking behavior, change their people, places, and things, and obtain as much time away from that old lifestyle so that when you do eventually taper off this medication, they are so far removed from that environment. So after all we've been over, if you're still on the fence about whether or not MAT works, here's the data to prove it. MAT is an evidence-based practice, okay? It has mountains of peer-reviewed literature and studies that show its high level of efficacy. Here in the figure to the right, we can see methadone maintenance as compared to placebo. Placebo is in red, showing that those who took placebo continued using opiates up to 90% of the time, where those who were given methadone in blue used opiates less than about 60% of the time, and some were even as low as 25%. Here we see the same study done with buprenorphine or Suboxone. Results differ here a little, but the overall takeaway is that about 50% of the time, Suboxone is effective. And there are hundreds of these studies. And the fact that they're above 40 and 50 and 60% sometimes are absolutely amazing. These are really effective and they do work. So in summary and in closing, I just want to mention that some of these takeaways are really important. MAT is a harm reduction, and it is always most effective when coupled with therapy. And the difference between MAT and illicit opiates are apparent. They are different. MAT is an evidence-based practice and it does save lives. If you know or are someone who struggle with opiate use disorder or alcohol use disorder, these options are available. They do work and they are accessible. I work at one of our level 3.5 inpatient facilities, and we offer Suboxone, we offer Sublocade, and we offer Vivitrol. This is a great time to get on it because it allows the patients to get stable on these medications, work on some of their behaviors, and step down to a lower level of care. So I want to thank you guys for coming today, and I hope you learned something. And I want to ask that you join us for our next webinar held on May 16th. It's going to be on detox and the continuum of care. If you guys have any questions, I'll get to them, but I don't think there are. No questions. Okay, David, I think we could cut it. Thanks everyone again.